Umesh. So Kathy is now currently the director of the Center for Vaccine Development at the University of Maryland. She brings tremendous experience to her presentation. She's worked on ACIP and also on SAGE at WHO. So with that, I'll stop and hand it over to Kathy.
Thank you, Chris. What I hope to do today is really give a general framework, and then I know that we will follow with some specific vaccine discussions, and Shabir and Ruth, I think, will extend some of these observations. So just as a general introduction, we know that there is significant neonatal, young infant, and maternal morbidity and mortality globally. That maternal antibodies transmitted across the placenta prior to birth do confer protection against certain infectious diseases during the first month of life, and pregnant women are an accessible population. So immunization against selective infectious diseases is a potential strategy to reduce severe disease in mothers and newborn infants. We also know that this isn't a new concept. I won't go through this in detail, but we know that as far back as 1879, maternal immunization with vaccinia conferred protection to infants. There was maternal immunization with whole-cell pertussis vaccines as far back as 1938. And then, of course, the most successful worldwide maternal vaccination program, which was tetanus toxoid, started with the important study in Papua New Guinea in 1961. And immunization of pregnant women to prevent disease in the mother is also not new, and I have been involved in ACIP and influenza maternal immunization efforts in the U.S. And if you look back in the U.S. to the very first Public Health Service recommendations, which predated ACIP, you see there pregnant women listed as a high-risk group and recommended for vaccination. So, what are some considerations for vaccination during pregnancy? I started with this list in the MMWR when we really first formed actually a vaccination in pregnancy working group for the ACIP. And you see here we have disease burden. We've talked about that already at the top of the list. It's a little bit different though, of course, in pregnancy because you're talking burden in mothers and infants versus burden predominantly in the infant or the mother. And I'll get to a little bit more about that theme. You have effects on the fetus. There's the immunogenicity considerations. In terms of the immune response in the mother, the durability was important, and I'll give some examples of that, and potentially negative influences on the infant immune response. So again, if we're talking the whole risk-benefit value estimation package, we also have to look at the unique aspects that also might detract a bit from maternal immunization. There's safety, regulatory and legal considerations, programmatic, you can see public perception, financial, etc. I do think, though, it's important, while some of these may be obvious, to think through the characteristics that might be more important. There probably aren't many that are less important, but may be more important when considering vaccination of pregnant women. For example, the liability issue. You know, we may not understand it, we may not believe in it, but if there is in fact more litigation that results from vaccination in pregnancy, then that's a cost and a resource utilization that needs to be considered. So I borrowed this slide from Brad. Brad showed this slide yesterday when he talked about what influences government adoption of vaccines, and he talked about disease burden being important. And again, we've heard that today when we've looked at list of country priorities and morbidity and mortality and all of the different ways that we've looked at it. So if we look again at vaccines in pregnant women, the big difference is that we have a number of different considerations in where is the burden and where is the burden of vaccine preventable disease. So for example, if we look at influenza, which is licensed, recommended, and used in many countries, that's an example of a disease that has morbidity in the mother and morbidity in the infant. And so there's disease burden that could be prevented from this program in both of those groups. Tetanus, which we've heard about during this meeting, is similar, that there is protection afforded to the mother and to the infant. Pertussis, potentially you're getting some benefit in the mother. I'm not sure we know a lot or appreciate a great burden of pertussis in the mother, but certainly the mother may get pertussis, although we're predominantly giving the vaccine to prevent the severe disease in early infancy. And I threw on meningococcal meningitis, which is a different example, but this was really the idea that during the large meningitis A campaigns, we shouldn't exclude pregnant women from these campaigns, that they could benefit, although it's not necessarily a vaccination strategy to target pregnant women. I think you could also ask a question the other way around. Do pregnant women have to be vaccinated to achieve this protection? And for tetanus, for example, we know the answer is no. If you have a very robust pre-pregnancy vaccination program, you can achieve the same goal. For influenza, I would say yes. If you want to protect the pregnant woman and protect the infant, you have to do that through immunization of the pregnant woman. And that's because influenza vaccines change every year, and because the duration of immunity and antibody that needs to be transmitted to the infant is not sufficiently durable to protect from one pregnancy to the next or from a prior year. You know, pertussis in the United States, we've gone to vaccination with every pregnancy. So that's another example where if you want to achieve the protection of the infant, you do need to have a vaccination program, likely during pregnancy. I mean, there are certainly cocooning, or there may be other strategies, but from a vaccine standpoint, pre-vaccination is probably not sufficient in that case. Now, what about vaccines that could be, I actually didn't change the currently, that could be administered to pregnant women? And again, the paradigm changes depending on what vaccine you're looking at. Ruth is going to talk a little bit more about RSV vaccine. Shabir is going to talk about Group B strep. So again, I won't go into these specific examples. I will say that for early fetal effects, either pre-pregnancy or early pregnancy vaccination is going to be needed. So again, this whole idea about when you vaccinate, duration of immunity, because if we're looking at the public health value of vaccines, then we need to recognize if we give the vaccine late in pregnancy, it may prevent disease in the infant, but you're not going to get that full value in the pregnant woman if that's what you desire. So I do think it's important to think about it in that way. And if we want the burden to be additive that we can prevent, then we have to give the vaccine at the right time, and we have to give a vaccine that can protect for some period of time. So what about considerations that weren't on that ACIP list? And here are some that I came up with. Certainly, pregnant women have a major role as caregivers for the family, particularly if they have other children in the household. These other issues that we've been talking about for the last day and a half, economic productivity, work absenteeism, household poverty, I can tell you from being pregnant 3 times that you don't, lay in your bed with your feet up watching TV for 9 months. So pregnant women are holding jobs, they're carting water, they're caring for their family the same way that everybody else is. And so when we do consider the value estimation, we do have to consider their contributions to the economy, to the family, again, to household poverty consequences if they're removed from the workforce. I think we tend to have, and this to me really, this message came out very powerfully this morning, that we tend to have a short time horizon when we talk about vaccine effects. And I'm not sure, I'm pretty sure that we don't understand the longer term consequences of maternal or infant disease. And Ruth, I think you're going to cover that a bit for RSV. But it needs to be considered. And when you think about cognitive development and fetal development, and we really truly don't understand what these acute diseases, what and how they may be affecting those longer term consequences. I'm going to show you an example about just preventing healthcare visits and hospital stays, another factor that we saw in many of the economic analyses earlier today. We really haven't talked about vaccines as a tool to prevent or mitigate antibiotic resistance. And I think in pregnant women and young infants, it could also be to prevent antibiotic usage, where our choice of antibiotics or the side effects of antibiotics can be a different risk-benefit ratio. Certainly, there are lack of other alternatives with prevention in the early weeks of life. And we just heard about outbreak control and pandemic preparedness. Now, in many ways, you'd say, well, what does maternal immunization have to do with outbreak control and pandemic preparedness? But for example, for influenza, if there were an influenza pandemic and we wanted to reach pregnant women and they were a priority risk group, then it does provide some potential benefit there in that regard. So this is just an example. This is a study. It's actually one of the first studies I did on influenza, looking at the odds ratio for any cardiopulmonary event during influenza season among pregnant women compared to non-pregnant women. And again, this isn't an issue where we're looking at burden or debating burden. This just shows that the odds ratio to be hospitalized increases with each week of pregnancy. And when we showed these data, when we published these data, many people said to me, well, that doesn't mean they have severe disease or more severe disease than non-pregnant women. That just means there's a lower threshold for hospitalization. And my response is they may or may not have more severe disease. I don't think this study is the one that advocates that. But a lower threshold for hospitalization, to me, is an important reason to prevent influenza. Regardless of how sick they are, I don't think we want pregnant women in the hospital unnecessarily. So again, there's a difference between morbidity, meaning severe disease, and again, preventing excess hospitalizations for whatever reason these women may be being hospitalized. Now, I mentioned this earlier about the balance between immunizing early before the exposure and ensuring adequate time for immune response with duration of protection. And again, I think for maternal immunization, there's a lot more work that can be done in this area. We know that placental transfer is highly effective. We know that it is active. We know that it requires a healthy placenta, and it begins relatively early at about 17 weeks. And I think I would argue that in many instances, we're probably vaccinating pregnant women too late. And if we vaccinate them too late, then they can't accrue all of the benefits. And I know in certain situations, Shabir, in the study that you did, it was simply because you didn't have the vaccine in time. But if you don't have the vaccine in time, or whatever reason it might be, and you vaccinate too late, then again, the pregnant woman and the infant are not getting the benefit. We also know that there are certain diseases that are going to affect this: malaria, HIV, infection, the gestational age of the infant, and of course, importantly, the interval between vaccination and delivery. And this is just a study that looked at impaired placental antibody transport in HIV-infected mothers. And it showed that it was both due to a lower specific antibody level in the mother, as well as reduced placental transfer. So again, this is important to consider. And For certain diseases, but not all diseases, and I think pertussis is the example that's probably been studied best, you can have, as I mentioned before, the impact of maternal antibody on vaccine responses. And this is just an early study by Claire Ann Siegrist looking at that phenomenon. So for influenza, for diseases where we don't vaccinate the infant, it's not a problem. But again, for diseases where we do and we start vaccination as early as 6 weeks, it potentially could be. So just quickly, just a few points on influenza to emphasize a few of the issues that we've discussed in the last day. So this was really the pivotal study done by Dr. Zaman in Bangladesh and his colleagues. That was the first randomized trial of influenza vaccine. And this was done now over 10 years ago. There were 340 pregnant women in this trial, so I do want to make that point. When we're talking yesterday and looking at some of Brad's slides, and we're estimating vaccine-preventable disease incidence of 1 per 1,000, or we're in the 10,000 range, we're not going to get to those outcomes with 340 women. I also want to say that this wasn't a perfect study for looking at influenza vaccine effects. You know, a pneumococcal polysaccharide vaccine was actually the original vaccine that was going to be assessed, and the influenza vaccine was the control. But we can learn a lot from this study. One thing we can learn, and this is just jumping straight to the results here, is that the primary outcome most people focus on is the influenza test positive, so in the infant. So there was a 62% efficacy of influenza vaccine given to mothers to prevent clinical laboratory confirmed influenza in the infants. But if you look at the numbers there, it's not much. It's about 22 total cases. But as Brad has pointed out, if you look at the non-specific, non-laboratory confirmed outcomes, you see lower effectiveness, but you see more cases and greater impact. So for example, respiratory illness with fever, we see a clinical effectiveness of 28%, but we see there a difference of about 20 cases. The other difficulty that I have with this paper is there really isn't a person-time analysis that allows you to say, if I vaccinated 100 mothers, how many episodes would I prevent? So it's not exact in that way, but you get the idea. Similarly for clinic visits, you know, some pretty substantial reductions here when we look at some of those other outcomes, including a 35% reduction in the pregnant women themselves of respiratory illness with fever. So really the last time that Gavi looked at maternal influenza immunization as part of their investment portfolio, this is really what they had. They had some other information, but from the standpoint of randomized controlled trials and very high quality data, this is what they had. And here's what they said, and I think this is very useful information to look at this. There's the potential to uniquely benefit 3 high-risk groups: pregnant women, infant, and the fetus. It strengthens the maternal immunization platform and Gavi's contribution to maternal and child health. So again, when we look at an overall value estimation, Gavi considered that to be valuable. And the opportunity to shape the market to serve countries with year-round influenza circulation. So again, here are some pretty unique aspects of what might be considered valuable. What were the key challenges? The possibility that the health impact is not attractive. We simply didn't have enough data. Logistical challenges, and we know this to be absolutely true with influenza vaccines. And again, this isn't an influenza talk, but that is acknowledged. And low country awareness. So let's just look very briefly at 2 studies that have been published since then. This was the study led by Shabir and his group in South Africa. Again, it was actually 2 randomized placebo-controlled trials of inactivated vaccine in South Africa. There was a cohort with HIV infection and a cohort without. And you can see while the numbers in the non-HIV infected cohort were larger than in the Bangladesh study, they're still relatively small if we're looking at outcomes in the 1 per 1,000 range, for example. But just quickly looking at the results of Shabir's study, and I've presented them a little bit differently than they're presented in the paper. But here's our efficacy. If we first look at the HIV uninfected, we see about 50% efficacy for preventing laboratory confirmed influenza in the HIV uninfected women, about 50% in the infants. So for every 100 women you vaccinate, you actually prevent 1.8 cases in the women and another 1.9 cases in the infants. And so your total here for every 100 vaccinated is about 3.7. What about in the HIV infected? The interesting thing here, this cohort was over 2 seasons, this cohort was over 1. But these women, if you control for their exposure, they were both in South Africa in the same area and went through the same influenza season, the number of HIV-infected women with clinical disease and laboratory confirmed infection was much higher, was 17%. So what I say when I see this, whether they're in the hospital or not, and I don't know if anybody here has had flu, but these are women with febrile clinical disease. I'm not sure we want 17% of pregnant women, feeling like you feel when you have influenza with fever for 5 to 7 days on an annual basis. Now, we know influenza is quite variable, but that is still a very different attack rate than what was seen in the uninfected. And you can see while in the infants the efficacy was much lower, overall, again, the number of episodes prevented was similar to what we see in the uninfected. So here, for every 100 HIV-infected women that we vaccinate, we're preventing almost 12 episodes of influenza if we count moms and babies. And this was the study done in Mali, which was presented just this year. Again, similar design to the South Africa study, double-blind, randomized, controlled trial, not placebo-controlled. They used a meningitis vaccine. And I'm just going to emphasize one point in this study, and that is that duration of immunity, that, again, you can only prevent disease when you have the immune response and for as long as you have the immune response. And I think one of the most remarkable outcomes of the Mali study was really showing the decline, and in particularly the steep drop-off in efficacy between about the 4th and the 5th month, which coincided with the maternal antibody decline in the infants. And then finally, in both Shabir's study, and I'm just showing the Mali study for efficiency here, they did look at effects on birth weight and saw no difference in either study. In the Bangladesh study, and there have been a number of observational studies that have looked at effects on birth weight, I think, again, in the interest of time, it's easy enough to summarize them as it's complicated. However, I think the point of this slide is to show that these are potentially additional benefits that can accrue from maternal immunization trials and maternal immunization programs, and it's important to look at them. We're still waiting for the results of the Nepal data, but again, no effects on birth outcomes or birth weight was seen in either the Mali or the South Africa study. And just 1 or 2 points here on pertussis. First of all, it's possible that we've heard already today about tetanus vaccination in pregnancy. This is a combination vaccine. It would absolutely be possible. And why would we consider it? Well, we would consider it because severe disease incidence is highest in young infants. As I've already said, it's feasible. We can substitute a Tdap for a TT or a TD vaccine. And we know from the UK and now some other experiences that it works. You know, really the unanswered questions with this are burden of disease. How much infant disease do we actually have? Could there be interference with the infant series that may be more pronounced actually in low resource countries where wholesale vaccines are used and there's a younger age at immunization? And there was just a CID supplement on maternal pertussis vaccination and burden of illness on December 1st. I would encourage those of you who are interested to take a look at it. Some of the authors are in this room. Kate had an article and some others had articles in this supplement. And this is just the effectiveness of maternal pertussis vaccination in England that, again, shows quite high vaccine effectiveness that in that CID supplement has now been shown to be prolonged and with a different vaccine, a different Tdap vaccine over now the 3 years plus of the program. I'm not going to show that. So in summary, I think the approach to valuing maternal immunization will need to be flexible. And why will it need to be flexible? Maternal immunization, of course, isn't one program. It's a number of different vaccines that may be considered to be used in such a program, and each vaccine will have its own unique aspects. I also think we're going to have to be somewhat innovative in how we estimate value. You know, if you look at the potential benefits to the pregnant women, the fetus, and the infant, you know, are these additive? If a pregnant woman dies, should that actually count as 2 deaths in our mortality estimates? And what are these longer-term consequences? How do we learn more about them, and how do we value them? But I think overall that any more complete measurements we do of public health impact will apply to pregnant women as well. And we can't forget that. The economic consequences, as I talked about earlier, and everything else we've talked about earlier today is likely to apply to pregnant women as well. So that's all. Thank you.